All right, I think it's time to start. Welcome everybody who came for the grand rounds for today. We have a guest speaker out from the Children's Hospital of Philadelphia, and it's a great pleasure to introduce you Dr. Jeff Boris. He's a pediatric cardiologist. He did his training at the Denver Children's Hospital, and then he owed service to the United States Air Force, and he served the country for 7 years. And then he came back, and he's a pediatric cardiologist at the Children's in Philadelphia, and his clinical interest is POTS syndrome. So he will tell us his experience and what he's putting together for a new POTS center at the Children's Hospital. And I think he has drunk enough, Louis, and he's ready to tolerate the challenge of 45 standing up here.
Whoa, whoa. Thank you, Lazarus. Everyone hear me okay? I'm assuming that's a yes. Turn it on. Turn this up?
It should be on your waist thing. The green light on. Switch.
No. Oh, it's on. It's on. Yeah. Can you hear okay? All right. Thank you, Lazarus. Oh, yeah, I can hear that. That's, as a matter of fact, I think we're getting a little bit of, there we go. Thanks. Reverb. All right. Yeah, my interest has changed, I guess, to POTS. We have plenty of seats up front, by the way, for folks who are coming in. My interest has sort of changed to POTS. I'm a general pediatric cardiologist. I do ambulatory cardiology. And this one sort of just snuck up on me. I've been taking care of POTS patients for about 11 and a half years from when I started seeing my first one in the Air Force. And it's been one of those things where when you let people know that you can do something, that you have a special or niche skill, my clinic has now turned to all POTS all the time. And you know what? That's okay. That's actually a good thing, because I guess if you know how to do something and you get some decent results, it works. So let's talk about what POTS is, okay? So just a couple things. There are no specific disclosures. I will mention some brand names, and there will be some off-label uses mentioned. So some typical responses to encountering patients with POTS, right? Never heard of it. Okay, that's fine. I've heard of it, and I don't believe it exists. Okay. And of course, this one is, I've heard of it, I believe it exists, and I think I hear my mommy calling. I got to go. Some other things. These patients are crazy, right? Heard that one? It's not my organ system. It's not congenital heart disease. My cardiology colleagues can absolutely relate with that one, including the ones at CHOP. Who are very happy to have me see these patients. It's frustrating. Taking care of these patients would drive me crazy. I have no experience using those drugs. The patients and families are so needy. Okay. So let's talk about what's really happening. These patients do have better things to do. They're not making it up. It's not in their head. You know, a lot of times patients are told that you're just anxious. But you know what? It's hard to fake these symptoms. It's hard to fake these findings. Yes, there can be comorbid psychiatric disease, but if you were having acute onset of dizziness or palpitations or severe migraines showing up at any old time, unbidden, unexpected, with your buddies, or taking a test, you'd kind of get anxious too. It's sort of like the Chinese water torture. And if you had a chronic disease that was really debilitating, you know what? That would be kind of depressing too. It is nobody's organ system. No one owns this. So why do we as cardiologists see it? Well, we see these patients because of dizziness, syncope, fatigue, chest pain, palpitations, exercise intolerance. But they just as easily show up in your neurology clinic for chronic headaches. They show up in your GI clinic for dysmotility. They show up in your chronic pain clinics for chronic pain. They show up in your sleep centers for insomnia. Lots of stuff going on. It can be very frustrating. It can be very rewarding, though. I've had patients I've had a lot of patients actually and families be so thrilled that they get their kid back, that they're able to get back to school, that they're able to go and do things like play lacrosse or go to college, you know. Taking care of these patients isn't for everybody, just like everything that we do as pediatric specialists and subspecialists. We do things because we have a kind of a bent for it, right? And so taking care of these patients, or for those who have patients, are creative and have some perseverance. It is true. Few providers have experience with all these medications, and that included me. And I just had to take the time and do some reading and play with them and learn them, and hopefully my experience can kind of help enlighten you guys. All right. So, what is it? Why does it happen? Who gets it? Can it just go away? And how do you deal with it? So what is it? It is variable autonomic dysfunction. That's in any dysautonomia. It is more severe than typical neurocardiogenic syncope. So when we think about neurocardiogenic syncope, we think about vasovagal syncope, we think about cardioinhibitory syncope, those kind of things. This is beyond, like way beyond. POTS is the most common form of dysautonomia as compared to some things that you may have heard of, including Shy-Drager, pure autonomic failure, multiple system atrophy, Riley-Day syndrome. Of note, 10% of patients do progress to pure autonomic failure, which if you thought POTS was bad, that's worse. All right, so let's see. What really happens in POTS? Severe dizziness. This is probably one of the most common problems that these patients have, is severe dizziness. Tachycardia and palpitations. Hypo or hypertension. Their blood pressures can actually go up or down, usually down. Chest pain, typically chest wall pain, but they can have some costochondritis. They just tend to notice it a lot more. Intense fatigue. These patients will sleep 16 hours and be like, I am so wiped out. They'll have heat intolerance or cold intolerance. Most of the patients that I've seen have heat intolerance, which means that the heat makes their symptoms worse, and they would much rather be in Minneapolis. However, I do have a small cadre of folks who would much rather be in the Bahamas, and they do better in the winter. Brain fog. They cannot concentrate. Now, this is not your typical spacey teenager. This is a patient who is classically a good student, smart student, understands all the concepts being taught to them in class, walks out of the classroom, 5 minutes later, I have no idea what I just learned. Okay? Read a passage in a book. It bounced off their head. Read that passage again. It bounced off their head. I mean, they have to read it like 3-4 times to finally, hopefully, get the point. It takes a lot longer for them. Weakness. Photophobia. So sometimes they have some light sensitivity or some hyperacusis, phonophobia. Again, we talked about some secondary depression and anxiety. Chronic pain, both musculoskeletal as well as joint pain. Sleep disturbance. They can have insomnia, either getting to sleep, staying asleep, or both. Headache, especially migraine, but tension headache and other headaches, chronic daily, chronic persistent, can absolutely exist. Syncope. You know, despite all this, most patients don't pass out a lot. They get dizzy as all get out, but they typically don't pass out very much. Some, not a lot. And yeah, with all this garbage, it's the least severe dysautonomia. But wait, we're not done. Other stuff. But wait, there's more. How much would you pay? Oh, no. So GI problems. They have delayed gastric emptying or gastroparesis. So they have dysmotility. Nausea plus minus vomiting. Chronic abdominal pain. Constipation. Diarrhea or cyclical changes. Bladder dysfunction. Venous pooling and modeling. So these patients, even if they're sitting for a while, their feet and their hands turn purple, blotchy, kind of full. Exercise intolerance. Exercise makes them, if they have a good day and they want to get back to what they were doing and they exercise like they used to for half hour, 45 minutes, an hour, and then they're dead for the next 3 days. Their symptoms are often worsened with upright position, but it can certainly occur in the supine or seated position. It's worse around their periods, that is for the girls. It's worse with an intercurrent infection. So for you or me, what would be a little sniffle, a little sore throat, a little nothing that, gone in a couple, 3 days, kicks their butts and puts them down for a week, week and a half. The symptoms can be variable. It can be day to day. It can be month to month. And then there is a creature out there called the October slide, which typically mid-September to mid-November, these patients just fall off the table. So it's really frustrating for not only the patients, but siblings, parents, teachers, friends. Well, you look fine. What's the problem? You were just fine. I just talked to you on the phone, and now you can't go out with me? That kind of thing. All right, so this T-shirt says, imagine POTS for, it's kind of hard to read. Imagine POTS for yourself. Number 1, fast for 24 hours. Number 2, donate a pint of your blood. Number 3, go home and turn your thermostat up to 100 degrees Fahrenheit. Number 4, stand motionless. Enjoy the symptoms? Okay. So a lot of people have been going and, are saying, gee, aren't we noticing this a lot more now? As a matter of fact, I think I just heard that in the audience just a little bit ago. It's actually been around longer than we think. So a surgeon named Jacob DaCosta in the Civil War actually described this in patients who had a febrile or diarrheal illness, soldiers. And he described this in 1871. And these patients were otherwise well, healthy, normal, had a febrile illness, had a diarrheal illness, and they were just profoundly dizzy, profoundly tachycardic, couldn't get up. Pretty impressive. Eventually called soldier's heart, also called, has various names in time, neurasthenia, effort syndrome, irritable heart, so kind of, different things that it's existed through time. Cardiac neurosis, that's always a good one. And about 15 or so years ago, a guy named Philip Lowe down at Mayo, an adult neurologist, came up with the concept of postural orthostatic tachycardia syndrome. And it's been demonstrated to exist subsequent to that in kids by a guy named Julian Stewart, who's in New York. So why does it happen? No. Sorry. We don't know what's happening yet. Lots of different reasons, though. Lots of things happen to it. So an antecedent viral syndrome, especially EBV, it's like the mono that never went away. Influenza, others. I would say about half the patients who I see have joint hypermobility, if not more. Now, that doesn't mean all of them have EDS, but a fair number of them have Ehlers-Danlos syndrome. Now, the problem is that how do you define EDS? And that actually is a debate in and of itself, because we don't have a really good test for it if it's not vascular. So some people call all hypermobility EDS, and some people call only the severe stuff EDS. Spectrum, right? Post-concussion, I'd say about 10% of the patients whom I see have post-concussion POTS. And we get a lot of the soccer players doing that. I can assume here there's a lot of hockey players who would get concussions. Mitochondrial defects, seen a few of those. Eosinophilic esophagitis, other allergic GI stuff. Gluten-sensitive enteropathy, plus minus, maybe. Diabetes, post-chemo. Is there an abnormality of the neurotransmitter receptor? There have been some folks who have some genetic neurotransmitter receptor abnormalities. Those aren't common. A lot of times it's idiopathic, from the Greek idio, meaning I don't know, and pathic, what the hell I'm talking about. It's rapid growth or hormonal change kind of sets a lot of these patients off. They just hit adolescence and it absolutely can be familial. I see parent-child dyads. I'll see siblings who have it. I'll see siblings' cousins who have it. Definitely see it in families. I think in the end, and because we're all trying to get our hands around it, a lot of this is consensus now, but I think, POTS is probably a secondary, final, common end process to some insult, to some event, to some occurrence. In adults, thank God we take care of kids. In adults, it's even worse, right? Porphyria, syringomyelia, fibromyalgia, diabetes, paraneoplastic. No thanks. So yeah, it's the uninvited house guest. Most of these kids were well, and then they weren't. These kids can tell you, or the families can tell you, the month, if not the date, that things in their lives changed. It's like I said, it's the mono that never went away. But some of these patients have always had kind of issues. They've always had sort of, the parents have always said, GI issues, some GI stuff, abdominal pain, or chronic headaches, and then something happens that just pushes them further over. So chronic migraine. And then maybe like some infectious event or something to that. And then some of them just got bonked in the head. That would be their concussion, right? So who gets it? It's typically seen in adolescent girls, and the ratio is 5 to 1 in the literature. I'd say that's probably close. I would guesstimate in my practice it's probably 3.5 to 4 to 1, but it's probably reasonable. But it is seen in boys, so don't dismiss it. You can absolutely see it in kids below adolescence. I have a 5-year-old, a 7, and a 9-year-old who have it. So it's real. These are often high-achieving patients, academically, athletically, or both, but not always. So it makes it harder because they have harder to fall and harder, or further to fall and further to scratch back up to get to where they need to be or where they want to be. So can't it go away? Well, the good news is a lot of these patients do outgrow it. Reportedly, 75% of these patients between age 21 to 25. Are these real? I think we need more data to really demonstrate this, but I think a lot of patients do improve with this. So until that time, what do we do for them? Well, we want to be able to manage their symptoms. We want to be able to then use the symptom management as a bridge to allow them to get to be able to exercise, because I think one of the things that we're starting to find is exercise on a routine basis, including core and leg strengthening, really does help these patients. And then reduce the medications as their symptoms improve and their exercise increases. So how do we make the diagnosis? The history, like everything else, is very, very helpful for these patients. I think taking the time and really asking and going through all these things with these patients, and I kind of have the litany in my mind. And actually, I understand this is an EPIC institution here. We have EPIC at Children's Hospital of Philadelphia. And what I'm doing, actually, Lee, what I'm doing is we're starting to work with NoteWriter. And what I'm going to have on my clinic, specifically my POTS clinic, will be kind of a test bed for NoteWriter. And we'll just have the symptoms listed on the screen, and you either click plus or minus. And then if you want to comment on it, you can free text in there. And by the way, NoteWriter, this is my plug for my other job. I'm the physician clinical champion for the Cardiac Center for EPIC, so I get to do this 30% time. It's discrete data, so it stores it in a flow sheet, so you can pull it up later. Anyway, back to this. History is, again, most helpful. On physical examination, what should you be looking for? These patients have orthostatic intolerance. Their heart rate jumps at least 30 points from supine to standing position in the first 10 minutes of standing, or it goes over 120 beats per minute. Now, I will tell you that the folks at Mayo published an article within the last year and a half or so saying that they, for teenagers, upped it to 40 points. But Mayo does tilt table testing. And with tilt table testing, you will have a much higher heart rate change. The other aspect of it is they said that a third of asymptomatic patients adolescents had a 30-point change, which I find, but again, that's on tilt table tests. So I'm sort of like, so what does that mean? If they don't have the rest of the syndrome, they may not show hypotension. And you get the extremity modeling, the venous pooling, that kind of stuff. By the way, again, for folks in the back, we have seats up front. Please come up. Don't be shy. I think the feeling is that you really need both the significant historical features and the heart rate changes for the diagnoses. So what about testing? A lot of times by the time I see these patients, a lot of the tests have been done. A lot of people do a CBC and a comprehensive metabolic panel and a urinalysis and all that other stuff. What are the things that baseline we ought to make sure that we get? And at least look at your thyroids. At least look at a ferritin, an AM cortisol, and a vitamin D. Probably those are the reasonable things to look at. So what about tilt table testing? Well, back in the day when people were really starting to look at this, not only would they stick them on a tilt table, but they would do this complex catecholamine testing, so they would get their metanephrines and their epinephrine and their dopamine and this and that and the other thing. And I think what has been found is, number one, getting these serum catechols doesn't really help you from a prognostic or therapeutic standpoint. And a lot of these numbers are all over the joint, so it's really not predictive. Number two, it wrecks these kids. It flares their POTS and makes them worse for 2 to 3 days. So this is one of my points that I don't necessarily agree with Mayo, but even though they've been doing it their way, I think that it's very easy to get a 30-point heart rate change in the clinic with a standing test and be done with it. So anyway, just personal thoughts. Do these patients need to see other folks? Well, so here's how we've been doing this at Philadelphia. I've been acting as a primary care manager. I've been acting as a primary care physician, if you will. So I will try to manage these patients' symptoms primarily, and we'll talk about how I do that in a little bit. And if I get through my run of things and I can't get there from here, then I go ahead and have them seen by other folks. So we have a dysmotility center in our GI division. For bladder problems, I will go ahead and send these folks to urology. Biofeedback works great for these kids. For patients whom you suspect may have a mitochondrial myopathy, your metabolic folks can be helpful. Which patients do I think need those? Those are the ones that have progressive worsening of their symptoms. They just keep getting worse and worse and worse. Most folks with POTS, they kind of come up, and then they sort of plateau out. They might flare a little bit, but they don't just have progressive worsening of their symptoms. Headache center, very helpful. I only use a few meds personally for headaches, but our headache folks, including going as far as using things like Botox and whatnot, can be really helpful. For folks whom you suspect have Ehlers-Danlos syndrome, connective tissue disorder clinic, or your genetics metabolism folks, we have three different CTD specialists in our metabolism division, and they all have 3 separate ideas on how to diagnose EDS. So what I do is I sit there and say, okay, are you hypermobile? And I see if they can, do the wrist thing. And have you dislocated or subluxed? Have you, do you have abnormal bruising or bleeding? Do you have abnormal scarring? Is your skin really stretchy? Do you have joint pain? I think if I get more than one yes to that, I tend to go ahead and refer them. So what do? Well, our connective tissue folks will say, talk to them about physical therapy and protecting their joints, and then we as cardiologists say that, well, okay, so the literature says in about 10% of patients with hypermobile EDS, there is aortic root dilation. So we'll typically get an echocardiogram. But if it's normal, I'll look every 3 to 5 years, so it's nothing super crazy. And then for comorbid issues, such as psychiatric stuff, I will go ahead and refer. Counseling, I think, is very, very helpful for these families, for dealing with chronic disease, the patient and the family. And what I try to emphasize with them, and this is something that I picked up from Blair Grubb, who's another world expert in POTS in Toledo. None of us are born with the tools in our toolbox for dealing with chronic disease. And so therefore, counseling doesn't mean that you're crazy. It just means that you need to acquire these tools. So it's helpful for the patient and the family to be able to go ahead and do this. So it's sort of like going to Home Depot or Lowe's to get those extra tools, right? All right, so how do you deal with it? How do you treat it? I kind of have a tiered approach that I talk about with the families. Level 1 is the activities of daily living. You get up, you get toileted, you get showered, you get dressed, you get breakfast, you get your normal day going. Tier 2, education. Back to school, period. Got to get going. Sometimes I'll do sort of shortened, an IEP or 504 or some accommodations, but by and large, they really need to be getting back to school. And then, of course, level 3 is the fun stuff. Hanging out with your friends, playing in the band, singing with the chorus, doing sports, going out to the mall, making sure that you're getting that stuff going on too. It is important to validate that these patients are not crazy, that they can stop chasing 5,000 different doctors around the country, over the last 1, 5, 7 years. Here, this is your diagnosis. This is what it is. Persevere and reassure. I don't give up if you don't. I say that to all my patients, actually. That is something that I tell them. I do use both somewhat protocolized as well as individualized therapy. I use non-pharmacologic and pharmacologic treatments, and we'll talk about that. And realize what works for one patient doesn't always work for others. So one size doesn't fit all, and I think we're definitely seeing that both in the literature as well as practically. Straight up, non-pharmacologic. Keep that tank full, 60 to 80 ounces of fluid. Now notice I say fluid, and then when I comment on that, I say water or milk. I don't say juice, like a good pediatrician, and I don't say Gatorade either. And the reason I don't is because of all the corn syrup and calories in there, despite the electrolytes. Now, could you do Pedialyte? I suppose. But if you're doing salty snacks, which is the second thing, and when I say salty snacks, I say pretzels, saltines, pickles. Notice I didn't say chips. Okay, that's all right. Different places do different things. Some places say an extra gram a day. Some places say 7.5 grams a day. Whoa, that's a lot. Supplements. So typical salt tablets over the counter, just so you all know if you've never done this before, are 1,000 milligrams, okay? And most but not all patients, when they take 1,000 milligrams of salt in a big belly bomber salt tablet, it upsets their stomach. It's very uncomfortable. So I use different salt supplements that are maybe anywhere from a fifth to a third that amount, and just use it a little bit more frequently. One of the ones that I use is something that you can get online at Amazon called salt stick capsules. Another one is called thermotabs. Either one of those are a lot easier on the tummy. No skipping meals. No caffeine. Caffeine's a diuretic, not so helpful. Good sleep hygiene. Yeah, this is why my initial appointment with a POTS patient is 60 minutes, because we have to talk about good sleep hygiene and telling him how to do it. Elevating the head of the bed on a cinder block, so sleeping on a little bit of a tilt. It's tilt training for the uninitiated. That's what it is. It's actually doing some tilt training for these patients. So, and I say to them, not extra pillows, not the mattress, the whole head of the bed frame up on a cinder block. Sleeping like that. Sometimes I will go as far as referring patients for something a little bit outside the normal, like or more than outside the normal, typically to a decent osteopath who is very familiar with craniosacral manipulation. Chiropractic? No way. Sorry, guys. For those of you who like chiropractic, not in these kids. Actually, not in any kids, in my opinion, but that's me. So avoiding triggers, so avoiding prolonged standing early on, and extreme heat or cold. One of the things that can be really helpful for these patients is a cooling vest. And there's a couple of kinds of cooling vests out there. There's some that have these gel inserts that you put in the freezer, chill them down, put them in and put them on, and that works 4 to 6 hours, works kind of nice. There's another one that, another kind of cooling vest that it has this new material. Some of you might have heard of frog togs or some of these other cooling towels that you see on the sidelines of the football fields. It has this material that you dunk it in water, wring it out, put it on. You don't get wet, and it's evaporative cooling. And those are cool. Those are literally, but figuratively, they're really nice. They work, and it allows the families to be in the house with the kid, and they're not getting blown away by the huge air conditioning bills. Leg strengthening and core strengthening exercises. If the patients are hypermobile, what I will do is I will refer them for physical therapy, and I will say, help strengthen legs and core, protect and stabilize their joints. And I have been using a protocol that was put together by Dr. Benjamin Levine in Dallas. It's a 6 to 8 month protocol in which these patients start off exercising just 10 minutes a day, 5 days a week, low and slow. They're not upright. There's no orthostatic stress. They start off on a rowing machine or a recumbent bike or swimming, and they slowly build up over time. So they build up their endurance. And also what you're doing is by strengthening legs and core, you're improving the muscle pump that gets blood back up in the active, what we call active upright position. So the walking around that I'm doing is also helping to bring blood up into my core and back to my head. Compression stockings works for some patients, not all. You wear them while you're awake. You wear their waist to toe, at least 30 millimeters of mercury compression. They can keep you really warm in the winter, so actually up here might work pretty well. They're hard to get on. They can be a little uncomfortable, but for the patients for whom it works, they really do like them. All right, let's talk about medicines. So the typical stuff that everybody hears about in these patients for use, Florinef. Fludrocortisone is a mineralocorticoid that holds on to salt and water, works nicely. It ain't perfect. Not everyone responds, but a lot of patients do respond. Had pretty good results with it. I only use up to 0.2 milligrams. If you look in the medical literature, and my endocrine colleagues may comment, the literature suggests that if you go above 0.2, like 0.3 or higher, that you get a lot more of the glucocorticoid type side effects. And I'm just not interested in going there with that kind of risk for these patients. I will check for hypokalemia and hypomagnesemia in the higher dose. Midodrine. Midodrine is an alpha-1 vasoconstrictor. It is the only oral vasoconstrictor out there. And it helps to increase your blood pressure. It lasts 3 to 4 hours. So you take it TID, but not morning, noon, and night. You take it on a schedule, 8, 12, and 4, 7, 11, and 3, that kind of deal. Side effects, it can give some scalp tingling and goosebumps, which is kind of funky. However, it's typically transient. Rarely I'll have patients where it lasts the whole 4 hours and then I can't use it. Proamotine, which is the original trade name drug, there's now 5 generics, but the original trade name drug supposedly had fewer side effects. I have not seen that in practice. The other thing that it can do is it can cause supine hypertension, so I'll just get patients to do a one-time 1 hour post-dose supine blood pressure and make sure it's normal. Now, beta blockers have been used as well, and what I tend to use beta blockers for are headaches, palpitations, and tachycardia, persistent tachycardia, despite having adequate fluid intake. We know that it can cause some exercise intolerance. It can also very rarely unmask depression, but I've seen it a few times. It's kind of a bummer. I have used it in asthmatics, and I have gotten it to work. It does okay. I don't use it in my diabetics. I think it just is walking that line too close. Some patients who have more fatigue with it or more depression, you can try using nebivolol or Bistolic, which doesn't cross the blood-brain barrier. So that might be a different option. Okay, you thought that was good. Here comes the weird stuff. So as I tell the patients, I use these medications for what they actually do, not for what they are marketed. So this is the off-label stuff. There are some patients who have very sensitive medication responses, so I tend to start on the low side and go kind of slowly with them. Know the side effects, and you might have to do different meds for different symptoms. It's just, you know, it is an approach. One of the medications that I have used a fair bit is Mestinon, pyridostigmine. Mestinon, as you may remember from medical school, is an acetylcholinesterase inhibitor. It's used in patients who have myasthenia gravis. When I got to CHOP 6 years ago, I found that the medication, like I said, these medications weren't working. I had to really branch out and read and do and stuff. And so one of the things I did was I just threw Mestinon at everybody because I read that Mestinon, in the literature, that Mestinon works. Mestinon doesn't do squat for POTS. But my patients were coming back and saying, you know, I'm eating better. My constipation is better, blah, blah, blah. And actually, I found an old article comparing metoclopramide, Reglan, with Mestinon. Reglan's actually a better prokinetic agent, but we all know about Reglan. I do recommend taking it with food, though, starting off BID and taking it with meals. Celexa. The SSRIs I have been using, I was using initially, and I tend to use Celexa more than, say, Zoloft or Prozac just because it's weaker and has fewer side effects. For sympathetic nervous system modulation, the folks at Mayo use it for GI issues also. I haven't had that kind of luck with it. I tend to use the SSRIs and also the SNRIs like Wellbutrin more for some of the, a little bit more for some of the mood stuff, but also just as sort of third-line therapies anymore. I will use Cymbalta. Cymbalta is good for chronic pain. It's a decent drug, I've had a little bit of pushback from the insurance companies, but not too bad. But it does work. Yeah, this is what actually really freaks people out, is doing this, stimulants. So these patients, what I'll do with these kids is I'll say, tell me, what are your 3 worst symptoms? And they'll say, you know, they might say dizziness, they might say the GI stuff, they might say headaches, they might say insomnia, blah, blah, blah. But one of the things that often comes up is the severe fatigue and or the brain fog. I've had patients tell me that stimulants are life-changing for them. They don't respond the same way ADHD patients do. These patients, the POTS patients, they take their stimulant and they're just like, okay then. Let's go. And they do better. Go figure. So Ritalin, I usually start with that because the insurance companies give me the least pushback and it's cheapest. Daytrana, Adderall, Vyvanse, Focalin, Strattera. Haven't had great luck with Strattera. Have had no luck with Concerta. I don't know why. But I will switch it up if patients don't tolerate Ritalin. I'll put them on Adderall, and they'll often do better with it. Provigil and Nuvigil. So for those folks that don't know what these drugs are, Provigil and Nuvigil are medications that are used for sleep phase disorders, for narcolepsy. The U.S. Air Force used them for their long-range B-1 bomber pilots who would fly over the pond from Whiteman Air Force Base in Missouri to the Middle East, do their work, turn around, fly all the way back. 16 hours in the office that day. So that's what they use it for. It works. I have found that these drugs don't do a lot for the brain fog. They can sort of help for the fatigue, but what I've done is if I have patients on much higher doses of a stimulant, I can actually potentiate that stimulant with a Provigil or Nuvigil and bring down their Adderall dose or Ritalin LA dose or whatever. Other stuff. Scopolamine, the old seasickness patch, works. And if the patients are having really bad sweatiness, not just the nausea, but the real bad sweatiness, they really love you because you've made 2 things go away with 1 drug. Way cool. The one problem with it, 2 problems really. It can cause some blurry vision for those folks who have ever used this patch before. So what I'll do is I'll say, cycle it. Instead of wearing it for 3 days straight, do 2 days on, 1 day off. or a day and a half on, a day off. The other thing, too, is it can cause a contact dermatitis. If you pre-treat, if you get one of these contact derms, pre-treat it with 1% hydrocortisone cream, half an hour beforehand, done. Works well. Zofran, my buddy, good for nausea. For excessive sweating, Drysol or clonidine or Robenol have gone there too, if that is something that's really causing them problems. And I will have patients who, they say, my palms are awful, I put on a shirt, I take a shower 3-4 times a day because I put on a shirt and within 30 minutes I'm like schwitzing. What about sleep? Insomnia. I start off with sleep hygiene. Melatonin, however, is a really good drug, or a really good supplement, actually. I start off low and slow, again, with that one, 0.5 milligram. Move up to 9, some people say 10 milligrams, take it an hour before bed, but I move up slowly on a weekly basis if they need it. I let the patient and family kind of have that control, just determine what they need. Sometimes they don't respond to that, or their sleep-awake phase is all messed up, and what I'll do is I'll just hit them with 2 weeks of Ambien just to straighten them out, and try that, or Lunesta. You have to be careful with Ambien and Lunesta. The big side effects with those are parasomnias, sleepwalking, sleep talking, sleep eating, sleep driving, sleep sex. Okay, so clonidine I will use, though, and just have to be careful with the dizziness. But actually, that works reasonably well, and trazodone works nicely, too. For those that don't know, melatonin can also cause some vivid dreams, so just be aware if the patients complain to you about that. For some patients, from a GI standpoint, Mestinon doesn't quite get them there because they're having diarrhea, or they're having diarrhea and constipation in cycle. And so these patients may have small intestinal bacterial overgrowth. So I use a modified protocol from a guy at WashU, a guy named Dr. Weinstock. You can do some lactulose breath testing to prove that they have it. Sometimes you can just, or you can just go ahead and treat them empirically. It's a week of Flagyl or a week of rifaximin. The insurance companies tend to have grief about rifaximin. And then do a month of zinc and a probiotic. And that actually does work for the recurrent nausea and diarrhea / constipation cycle. Chronic pain, Lyrica, Savella, Vimpat. Headaches, Periactin. A lot of people respond nicely to Periactin, but you have to be careful because it increases your appetite. And so the girls don't like that, especially. The guys are like, woo. But some of the patients have them eating with squat, so they appreciate it. So it's all right. So you have to kind of be aware of that. Verapamil works fair for headaches. And then I'll go to metoprolol after that. So yeah, I do a little polypharmacy for these patients, but I use the medications to improve their symptoms so that they can get, so not as destination therapy, but as bridge therapy, so they can get to the exercise portion. And they can also do this. They can get back to school. Sometimes they need an IEP or a 504 with some stuff that they can do, a couple sets of books, one for school, one for home, maybe an elevator key, some extra time, maybe someone to walk with, make sure that they have their water bottle and salty snacks, and the ability to self-limit or a place to chill. Interestingly, the library may be better than the nurse's office because it's colder or cooler and quieter. Some folks do partial day or virtual school or homebound. I really don't like to do that. And there are some places there are some places that don't let you do it at all. I'm still sort of working out how I'm going to deal with this over time, but some patients need it. May need to limit some PE. They might need some accommodations for their SAT or ACT. Interestingly enough, and then for college, maybe a first floor dorm room, air conditioning, private bathroom, the ability to tape record their lectures. Interestingly, though, college is often easier for patients because you're not doing 1 to 5, 1 to 6, 1 to 7 periods 5 days a week. 2 classes today, 2 classes tomorrow. You've got some time to recover. You can, and then what I'll do is I'll actually ask for them to be able to sign up for their classes a little bit earlier so they can, before the other class, for the rest of the freshman class, for example, so they can get a late morning class. Because a lot of the times these patients are better in the later morning or afternoon. The other reason, too, is that these patients, by the time they're getting to this age, they're more aware of themselves. They're more aware of their triggers, and they're more aware of the disease. And so and I tell them, you got to own it. You have to have ownership and deal with this yourself. The things that you do will influence how you feel. If you stay up late, you'll flare your POTS. If you go out and drink, alcohol is a diuretic. Alcohol is also a peripheral vasodilator. You'll flare your POTS. And they're like, okay. So it is kind of new, It is a new frontier. There's some new things to play with out there. Ivabradine, I don't know if you all have heard of it. It's available now in the EU. It's a medication that's used for tachycardia. It works specifically on the sinus node. It's kind of cool. Some old therapies, IVIG, potentially. These patients were well and then they quit being well. So is this an autoimmune thing that happened? So potentially consideration for that. Biofeedback, plus minus. I think it's part of. The folks in Dallas, there's an outpatient person in Dallas who does biofeedback only. I'm not wholly impressed that as a sole modality that works. And then exercise, as I mentioned. So this sort of came to fruition because after mentioning, as I said before, that I see these patients, and now I'm booked out several months, and my clinics have turned it into all POTS all the time, I figured, let's do this right. So we're going to actually have a center for pediatric patients with POTS. And, if you think about it, what we're doing is just sort of codifying what we've already had in place. We already had the headache center and the dysmotility center and the CTD and physical therapy and rehab and adolescent and concussion and metabolism, of course, in cardiology. So, those already existed. I now have an NP who's helping to improve throughput so he can see a lot more of the follow-up patients so I can get the new patients in. We'll get some data going, get a database going, maybe do some clinical research with this, and get a sense of one of the things that I want to do with this is make this more patient-centric. So many people have, for so many different clinics, have a multidisciplinary clinic where they bring all the docs and providers, as OTs and speech therapists and PTs and whoever else, into one room and they parade the patient in front of them. So it has very little throughput for the patients, and so there's a long wait for them, and you get the point. So this is more patient-centric. Not everybody needs to see all these providers. So it's more of a primary care approach where I can go out to the satellite clinics, which I do. I work in 4 different satellites, plus downtown. We have a very extensive satellite network. And see the patients there. Much easier. So what that also means is if they need other services, like counselors, I need to know how to get them there. As I mentioned, a database, we can review and report some outcomes and get some stuff in the literature and really start being vaguely scientific about this. As I mentioned before, trying to leverage the electronic health record so we can capture this discrete data. And then cultivating education amongst both internal and external providers. Let me tell you, I work with 55 cardiologists, and the number of cardiologists that I work with that don't believe this exists is high. But they say out of the other side of their mouth, we're so glad that you're taking care of these patients and not us. From an administrative standpoint, it is a new revenue stream for a hospital. And so from an administration standpoint, people actually like this concept. You have the direct patient influx, and you have the downstream referrals. So, and testing for those folks that do testing. So what are other places doing? Well, so I just came up here from a visit with Phil Fisher and his team down at Mayo Clinic, and they're doing intensive outpatient pain management therapy. They work with the patients and the parents. It's a 3.5-week, $33,000 protocol. They reduce the medications, and they use a thing called tough love, which means they are tough on them, but they do it in a loving way. So it's not as if they're just beating on them and humiliating them and that kind of thing. They really, and so it sounds good on paper. We'll see how it do. I will tell you, I've had several patients fire me because they weren't responding to stuff, and they come out to Mayo and they did better. But not everybody. There's also folks who are refugees, if you will, from the program who just couldn't get there from here. So, it's like everything else. Biofeedback I mentioned. There are a lot of places, there are some places that are doing a lot of testing. Now, I'm not sure what they're doing with this testing. Does it really make a difference from a diagnostic, prognostic, therapeutic standpoint? Or are you just doing making a boat payment? I'm not sure what the deal is yet with that. There are some websites out there that that the parents will have found by the time they come to you, I promise. If they're even thinking about POTS, or if someone has told them about it. So just so you know, they're out there. All right. Hopefully that was a quickie, or not so quickie, but at least a little bit of a look at this class of patients. And hopefully that was helpful, and I'd be happy to answer any questions.
All right, good. Very, very nice presentation. Sounds much easier than in real life, I think.
No, it's once you get the hang of it, it's actually patients come in and they have these symptoms. You're like, okay, let's try this, and this, and they are so just to have a diagnosis, just to have an answer. They're so grateful. They really are.
So any questions from the people? I'm pretty sure some of you may have seen these people that Dr. Boris described here.
I'm a pulmonologist, and I see a lot of patients with exercise intolerance. And I've noticed over the last couple of years, this diagnosis is on their list, and they have vocal cord dysfunction syndrome. Do you see a correlation there? If you take teenage adolescents that are high achieving, it's kind of a setup, but is there a relationship physiologically or at the acetylcholine level?
Right, no, it's a good question. So the question is, from one of our pulmonologists, is in patients who have exercise intolerance during exercise stress testing, or just in general, he's also seeing POTS on the differential, as well as seeing an incidence of psychogenic vocal cord dysfunction. And so is there any kind of connection? And the answer is, I think from an anxiety standpoint, if there's associated anxiety, some of these patients do have psychogenic VCD. I think psychogenic vocal cord dysfunction, is probably more like a tic or an abnormal. They sort of forgot how to breathe, and instead of opening their vocal cords, they slam them shut as they're breathing in. And as you know, they have to be sort of retaught how to breathe. They go to a speech pathologist who can teach them how to use their vocal cords appropriately. I do not think that it is physiologically associated with this, because I see psychogenic vocal cord dysfunction in patients with or without. I've seen it rarely in POTS, but I've seen it in kids who don't have anything either. So I don't think it's particularly related. But good question. I did not mention that as one of my things that I see.
Thank you. John?
Yeah, just, so is there symptoms are typical, there's really no place for tilt testing as diagnostic, or you would only do that in somebody whose symptoms don't quite fit, and you're sure the diagnosis, or it's just a waste of time?
Right. So the question is, where does tilt table testing fit in the diagnostic method to this madness? And in patients who have, so I think, and I learned a lot of stuff this last couple of days too. I think by and large, tilt table testing is overrated. I think it's not necessary. I think that if you're not sure from a diagnostic standpoint, if the patient has a questionable heart rate response in the clinic, like it's 25, but yet thinks from a syndromic standpoint they have the symptoms, would a tilt table test be reasonable? I think that would be fine. I have to tell you, I use tilt table testing very rarely, I think, anymore. The incidence of false positive is about 40% in asymptomatic patients. So I use tilt table testing actually to diagnose cardioinhibitory syncope, because specifically in Lazarus and we were talking about this before, in cardioinhibitory syncope, so that's where the blood pressure and the heart rate drop. I've had very good results with using SSRIs to treat those, as opposed to Florinef. And so if I'm diagnosing that, and if I can't quite tell by the history, I'll do a tilt and do it that way.
Go ahead.
I do pediatric emergency medicine here at Wisconsin.
Great.
I feel like that the constellation of symptoms you described is an awful lot of people.
Yep.
Have a lot of vague kind of issues.
Yep.
And I struggle a little bit with what the threshold is for considering this and referring.
Sure.
And I guess I'm wondering how often you get referrals for consideration of POTS where you say, no, it's not POTS, it's something else.
Sure.
Or if it's like everyone who has those things might have POTS.
So the question came from one of our emergency department providers saying that this group of symptoms is kind of common, widespread, seen a lot. So what's the threshold to pull the trigger to send these kids, or how are they, how do they end up showing up? And what I would say is, interestingly enough, a lot of times these patients end up going back to their primary care providers first. And then they'll either do one of several things. They'll come in through our diagnostic center. So we have a pediatric diagnostic center. I know, do y'all have one here? Where you have, it's sort of like house but nicer, where you have a provider who's in the clinic and kind of puts everything together and says, I think you have XYZ. And so, and they'll go from there. Or they'll come through the headache or neurology clinic, or they'll come from GI or that kind of thing. I think when the patient is acutely ill, and it's viral and that kind of thing, I think you sort of have to say, well, look, this is a viral syndrome, and so blah, blah, blah. A lot of times these patients will come into the ED, though, because they're having severe dizziness. All the other stuff notwithstanding, I tank them up and send them home. So if you tank them up and you get in the history that you're having other stuff going on, then you can say, you might want to talk with your primary care provider about something like this. And as you well know, the emergency department is not necessarily the place that you want to start doing primary care management and diagnosis. I know you're sort of shrugging like, oh, we do it anyway. Yeah, exactly, right? So it is what it is. I mean, if you feel comfortable sort of saying, look, let's, I tanked you up. Let's do a 10-minute standing test and see what you got. And then, but by the same token, a little bit of dizziness. I see this all the time. In kids and in adolescents, they don't drink a lot. They skip meals. They have a lot of caffeine. One of my fun things to do is I'll find something kind of medium yellow, and I'll say, when you pee, is your urine that color yellow? And they'll say yes, and they'll say, yeah, so you're not drinking enough, Or of course everybody's trying to be healthy, so they don't have enough salt, right? So I'm like the cardiologist that says you can have salt, and everyone drops their teeth. So I think if it's not that, I think you have to have more than just a little bit of, dizziness, syncope. It's really, have an index of suspicion if you've got a lot more of much more severity to that. Does that make sense? Please.
The most severe patient that I manage is manifest weight loss. She had a 20-pound weight loss when she's not doing well, 12-pound weight loss.
Right.
She's actually coming in tomorrow morning because she's had a recent sort of 12-pound weight loss over the last couple of months.
Right.
She's not on any medical therapy. She's
Right.
symptomatic therapy. She's a trauma.
Right. So the question is, for a patient who, one of her manifestations is 20-pound weight loss. And so what I would ask is, and she's not on any medications at all, just doing fluid and salt and that kind of deal?
I've seen her twice, made the diagnosis,
Okay.
put her on fluid,
Yep.
salt,
Yep, so
exercise.
just fluid, salt, exercise. She's a track runner, and she gained the weight back and then has fallen off the table again. Okay, so literally and figuratively. So what I would do is I would go back to her and say, so how's your appetite? What do we got going on? Nausea, vomiting, diarrhea, constipation, early satiety. Early satiety is very common in these patients, even if they don't have the constipation. And so what I'll do with these kids is I'll actually, I will put them on, I will try Mestinon first, because they have enough dysmotility that even if they're not fully constipated, they're probably not having a good evacuation. And just try 30 BID with meals of Mestinon, and then I go to 60 BID if they need it, and then, TID with meals, and go from there. If it doesn't upset their stomach, and they're tolerating it well, in higher doses you can get diarrhea, because, salivation, lacrimation, urination, defecation, right? And then in much higher doses, some muscle twitching, but that's really rare. So that's an option. If she doesn't tolerate it, yeah, I think periactin's decent. Totally. Yeah. What else?
If there are no other questions, I have one question for you. You already mentioned that POTS syndrome is something that we see in a subtype of the Ehlers-Danlos syndrome. However, I don't know if it is a general knowledge or just my personal experience, is that a lot of the POTS-like symptoms, you see them in people who have, Marfanoid appearance, like they're tall, thin individuals, hyperflexible, without necessarily having the genetic background of Ehlers-Danlos. But even with the Ehlers-Danlos, what's the connection there? Because you're talking about autonomic dysregulation syndrome, and Ehlers-Danlos is a connective tissue. So is there any problem with the venous capacity, or how do you
Yes.
connect?
What's happening in these patients is it's a failure of their peripheral vasculature to vasoconstrict. Either their autonomic nervous system is giving them really crummy, mixed up signals, or in patients who have, have connective tissue disorder, as I say to the families, the connective tissues are stretchy. So if you think that the connective tissues in your joints are supposed to limit your range of motion, you're able to go beyond the normal range of motion, those same connective tissues are in your blood vessels. So the blood vessels just kind of go, and everything falls on the floor. So it's probably similar from that standpoint.
That was I was afraid, and that means that it's something different than autonomic dysregulation in this subpopulation. Perhaps they need a little bit of different treatment. Do you see that or no?
No. No. I still find, because not everyone with EDS or not even with joint hypermobility. I mean, there's tons of folks with joint hypermobility out there. All the gymnasts and stuff like that. They don't get this. So I think they're at greater risk for it, and. Again, there's a lot we don't know, but I think that still treating from managing both their symptoms as well as whatever autonomic issues really does make a difference for these patients. They can be more difficult to treat, I will say that, and I think that the physical therapy aspect of it, both to help them with their exercise as well as protecting, stabilizing their joints, is so important, not just for now, but for the whole future.
Good.